All right, guys, so in picking up with induction and augmentation, we left off with talking about Pitocin, that she needs to be effaced and somewhat dilated before we just start asking her uterus to contract. So we use cervical ripening agents. The examples of those are Cytotec or Cervidil the night before we start Pitocin. Once a woman is on Pitocin, she needs to be monitored continuously in labor. So that's with the external fetal monitor. So again, I want you to go ahead and watch this 5-minute video that will really put together the pieces that I'm going to speak about for the next 5 minutes on induction of labor. So we've talked about some indications. The first one, PIH, is another way to say, but what we're calling pre-eclampsia, and I will list it always as pre-eclampsia for you. So that's the high blood pressure of pregnancy. Chorea, what's that, right? If she has an infection in her uterus and she's still pregnant, we need to deliver her. And if she spontaneously breaks her water but doesn't go into labor within 18 to 24 hours, we can't just let her sit with her water broken beyond that 24-hour mark. We will start to induce her and bring on contractions. Clearly, if she's ruptured and at the 8-hour mark starts to show signs of infection, then we'd start that induction sooner. But we can safely wait 18 to 24 hours after water has broken in a woman who remains asymptomatic, so doesn't have a temp, doesn't have a white count. She can try and wait. Most women will go into labor on their own in those 24 hours. And then we talked about women with medical conditions. And then you guys also spoke today about the post-dates, so going beyond 42 weeks. You spoke about the small baby, intrauterine growth restriction. We will induce a woman if the baby is a stillbirth. We will bring her in to try to induce labor to have a vaginal birth. So we talked a little bit as well about who cannot be induced. Clearly, if she has an active herpes outbreak, we would not. If her baby was breached, as you guys pointed out, and again, if her umbilical cord has prolapsed, we're going to deliver by C-section. We're not going to induce her. If her placenta is down low as a placenta previa, that's the first thing that's presenting over that cervix, she should not deliver vaginally. She needs a C-section, so she would not be a candidate to be induced. So people who've had a surgery to their uterus before represent a special category here in terms of induction. So people who've had a myomectomy, it's a surgery to remove fibroids, which are benign tumors in the uterus. This myomectomy surgery is the same exact surgery as a C-section. It's just we are not removing a baby, we are removing fibroids. So if somebody has that in their history, we can safely assume they've had a surgery that is identical to what a C-section surgery is. Now, if somebody has had a previous C-section, they are a relative contraindication for this induction, and I want to just be really clear. If somebody's had a surgery to their uterus, as in a myomectomy or C-section, we don't ever use cervical ripening agents, so that would be our Cervidil or our Cytotec. We don't ever put those into somebody. That's a huge contraindication. However, if somebody has had this myomectomy or a previous low transverse C-section, we can do a low dose of Pitocin if we're very closely monitoring her. So again, no cervical ripening agents, but we can do low dose PIT in a reassuring fetal heart strip situation. So let me detail why this is the case. Okay, so if we look here, if she's had a low transverse incision previously, and now she's pregnant and needs to have an induction, let's say her second pregnancy, she has preeclampsia and we need to induce her. If her previous incision is this, the low transverse, we can be relatively well reassured that if the active 2/3 is what's contracting on that uterus, that we're not putting her at a huge risk for this incision to open, right? So that we can safely give her a little bit of Pitocin while closely monitoring her. Would we rather her go into labor on her own? Absolutely, but if she needs that little bit of Pitocin, we can give it in this context. If she's somebody that has had a vertical incision, or what we call a classical incision, you can see now we're getting into the portion of the uterus that is actively contracting. These two women should not be induced, not even with Pitocin, because their risk of that old scar opening up during contractions is far too high. In fact, women with this history will often have an amniocentesis, so an amnio, at around 37 weeks. Think about why that might be. Okay, it's going to tell us if that baby's lungs are mature, and if that baby's lungs are mature, we will deliver her at 37, 38 weeks to prevent her from ever having a contraction, because in those two situations, especially in that classical incision case, her risk of that uterus opening or rupturing is far too great that we don't even want her to contract or go into labor. Okay, the other contraindications to induction, and these are sort of relative. So if we think about these, I'm going to add here that these are more of our relative contraindications. So there may be times where you see a woman still being induced with these things. With twins, we'd much rather her go into labor on her own, but we may give her a little bit of Pitocin if she needs it. With too much amniotic fluid, polyhydramnios, again, yes, there's a higher risk of a uterine rupture because of the overdistension, even if she has never had a previous C-section. But it's a case-by-case situation with polyhydramnios, whether or not she'd have an induction or a C-section. We've talked about a woman who was preeclamptic can have an induction, okay, that's fine. But let's say we have a woman whose blood pressures are 190 over 110. We don't want to put her in pain from contractions and have her blood pressure skyrocket even more as a physiological response to pain. So severe hypertensives would not be a candidate. And then if we have a non-reassuring fetal heart rate tracing, so we have a category 3 fetal heart rate strip, then we would definitely not be inducing her, because we're not going to give Pitocin, which will make that strip worse to somebody who is already having non-reassuring fetal heart rate tracing. Okay, the other term that we've thrown out and discussed is labor augmentation. So what this is the woman who's already in labor. Let's say she gets to 5 centimeters dilated, and now all of a sudden her labor sort of stalls, right? She's no longer progressing. So in that woman, she's already in labor, but we may need to augment her. So give her some Pitocin to help move, to get those contractions to be what we call adequate, to start to dilate and efface her cervix more. So augmentation is somebody who's already in labor, but that labor may stall, and we're helping things along by starting to give her a little bit of Pitocin. This is where Pitocin is way overused in the clinical setting, and I think sort of abused in a lot of ways, that people turn to this very quickly when we should be a little bit more patient with women, okay? But in a failure to progress situation, instead of going straight to a C-section, we should be trying Pitocin first. In this situation, we'd also put in an IUPC to measure and make sure those contractions are actually strong enough as we're starting that Pitocin on her. So what do we do in all this, right? Again, this material is nursing care during procedures. So we need to make sure that we're tracing that fetus in an induction or an augmentation situation, because we're adding Pitocin, which can stress the baby out because we're making longer, stronger contractions that are more frequent with the Pitocin. The nurse, will be monitoring that fetal heart rate and also monitoring the maternal response to how mom is responding, both with her vitals and pain scale to the contractions. When a woman goes on Pitocin, it's not a nice stepwise fashion in terms of how strong the contractions build. It's almost like walking up a staircase, and instead of starting at the bottom, you start 3/4 of the way up the staircase. So the contractions don't start nice and mild. They actually start really strong right away when somebody's on Pitocin, okay? All right, so let's talk about these medications a little bit more and determine how we know who needs which one. So in thinking about the Bishop score, this is something that needs to be documented on all of our patients before they have an induction of labor. So the provider will have done a vaginal exam and determined what the Bishop score is and report that to you as the nurse. So a woman who's had a baby before is going to have a successful induction if her Bishop score is 5 or higher. For a woman who's having her first baby, it should be a 7 or higher. I define success as meaning and the induction is more likely to be successful, i.e. lead to a vaginal birth, if her Bishop score are these two numbers or higher. So you can go ahead and look and see what it would take, like what would that cervix be for dilation and effacement if it was a 5. So you can go down the 1 category and see she'd have to be at least 1 to 2 centimeters, 40 to 50%, right, in order to, if she's given birth before, in order to have a successful vaginal birth at the end of this induction. It's not 100% guarantee, but again, much more likely if she goes into it with this score at the start. So if she is this with the 5, she doesn't need a cervical ripening agent, guys, because she's already dilated. So let's say we have somebody, though, that is 0 centimeters dilated. Say she gets points for some of the other things, but she's only 0 centimeters. This is the woman who's going to need a cervical ripening agent. If her cervix is 0 and isn't very much effaced, she needs cervical ripening before throwing Pitocin at her, and that makes sense. We don't want to just ask that uterus to contract if the cervix is not open yet. So how do we ripen the cervix? We can use Cytotec, which is a pill form, or we can use Cervidil, which it looks like a flat tampon. Okay, Cervidil is the preferred method because this can be removed if there's fetal distress. You grab the string as the provider, as that nurse, and you can pull this out if the fetus starts to become distressed. This pill, once it's in the posterior fornix, which is the portion behind the cervix in the vaginal vault, that pill cannot be retrieved. So there's a higher risk for needing to go to a C-section in fetal distress with Cytotec than there is with Cervidil. So the patient usually comes in at night and has one of these placed, and it stays in for 12 hours. It gets pulled out in the morning. Usually it goes in around 6 p.m. and comes out around 6 a.m. We usually get the woman up to take a shower in the morning, and then usually around 7 a.m. she'd start Pitocin if her cervix has, changed and become favorable from this. So when a woman has these, we are monitoring the baby at prescribed intervals, and we're watching out. These two things alone might be enough to put her into labor, and that is a wonderful thing if that happens. You'd call the provider and let them know, your patient is now contracting, she's uncomfortable, this is her cervical exam, and that's a good thing, again, if these start labor. The Cervidil can go in for just 12 hours, and that's the only time it needs to go in. This Cytotec needs to be put in every 4 hours as well. So it's a pill that gets inserted into that posterior fornix Q4 hours. They do Cytotec at Yale. Cervidil is the more common, okay? So once she has a favorable cervix, so the cervix has opened or dilated, we then start women who are being induced on Pitocin, which is our synthetic oxytocin. We mix 20 units of PIT into an IV bag, and the order will be to increase the Pitocin by 1 to 2 MUs per ml until we have a regular contraction pattern. So by that regular, I mean she's contracting Q2 minutes, and they're moderate, okay? Moderate to palpation, okay? Moderate to palpation in strength. But Q2 minutes is a good curve. We don't want them any closer because that stresses out the baby. Now, if she is contracting more frequently than 2 minutes, the fetus will probably start to respond in a non-reassuring way, and we will be either turning off the PIT or going down on it. In that context, again, you don't need an order. The order will be written very clearly for you about whether or not you're increasing by 1 to 2 milliunits per ml. And how you decide that is by looking at her contraction pattern and the fetal heart rate. If she's not yet contracting Q2 minutes, you will go up on the PIT every 20 to 30 minutes, depending on the institution you're in. That's about an average. Every 20 to 30 minutes, you can go up on the Pitocin. We do get to a point where we need to stop going up on the PIT. So once you have increased it and you are at 20 MUs per ml, we would halt at 20. We don't go above that with a woman during an induction of Pitocin. Again, there'll be a clear order of how, whether it's every 20 or 30 minutes at your institution, and whether the provider has ordered it to go up by 1 or 2 every 20 or 30 minutes. And again, you are one-to-one with that patient, and you're really focusing on how frequently she's contracting to get her into about a Q2-minute pattern. And if she needs to go off of this at any point for fetal distress, you can be reassured and talk to the patient that the half-life of Pitocin, right, it's about 3 to 5 minutes, so it will be out of our system quickly if we need it to be. And you could see this page in your book for more information. I would encourage you to do that. This is what it's going to look like, right? PIT 20 units added to 1,000 mLs. I'm going to document that. And then, as we've talked about in class, why our intervention for fetal distress is to turn off the PIT is because the Pitocin in this image down here has made her contract too frequently. If you look right here, they're one on top of the other. She's not, it's about every minute, if not less. So that fetus doesn't have enough time to catch its breath, right, to get oxygen because it's just contracting, and we know there's no blood flow at the peak of the contractions. So in this context, we would turn off the Pitocin, right? So hypertonic uterine activity is a side effect, a risk of Pitocin. We would cause her to have too many contractions, hypertonic uterine activity. At an extreme, that can lead to a uterine rupture. It can make the uterus rip open, which is why if she's had a previous C-section, we're really careful. It's a relative contraindication. It's a big conversation about whether or not she should be going on Pitocin, okay? And clearly, if the fetus doesn't recover, the risks of Pitocin are that it could lead to a C-section delivery. So you can think about our interventions for if she's contracting too frequently and the fetus is responding negatively to that. Think about all the interventions that we've spoken about in class in terms of non-reassuring fetal heart rate. And you can see this page in your text. So by definition, that risk of Pitocin administration of hypertonic uterine activity is that her UC, which is uterine contractions, are lasting longer than 90 seconds. They happen more frequently than every 2 minutes, okay? And that there's late decels on the tracing. So we want to think about that, and again, what our interventions would be. Okay, so this material I'm going to cover as pre-material for Thursday. Will not be on the quiz, but we will discuss in class on Thursday if there's any questions. I realized if I don't give you a couple of minutes of this recording, we won't have enough time to get through the case studies in class, which I really want to have time for, which were on the agenda for Thursday. Okay, so an external version is when a baby fetus is in the breech position in utero, the provider can try to externally manipulate that fetus through mom's abdomen and flip the baby. Has about a 60% success rate. I would say each provider has a slightly higher or lower rate around that number, but that's as an average. We don't do it until 37 weeks because if this puts the baby into distress, we may have to deliver her. So we don't attempt to flip a fetus until we are at a point where we're fairly comfortable. If we needed to do an emergent delivery, we could. We give a medication called terbutaline, which I will discuss a lot more in the future weeks. But terbutaline might be a medication that flags in your brain as an asthma medication. Terbutaline targets beta receptors, of which there are beta receptors on the uterus. So it allows the uterus to relax, and a relaxed uterus will allow that provider to be able to more readily flip the baby. As nurses, our role during an external version is to monitor the baby. So we do a non-stress test, that fetal monitoring, to document that we have a reassuring, right? We wouldn't do this if we didn't have a reassuring NST first. So that we have a reassuring NST before we go in for this version. And then we monitor the patient again for about 2 hours post-procedure. And let's talk about why. So this is what's happening. This baby's going from breech and the provider is going to flip the baby. It is uncomfortable for mom. It definitely is. So this is it happening in real time. You can see the provider and how hard that provider is pushing. We do lubricate with ultrasound gel the belly. That helps a little bit for the provider. So the contraindications are listed here. If the woman has any of these things, we wouldn't even attempt. We would just schedule her for the C-section. The risks of having an external version are listed here. We could cause, this is called an abruption, right? This is when the placenta detaches from the wall of the uterus. She could need to have an emergency C-section due to fetal distress, which is right below it. We could inadvertently cause her to break her water. And the other risk is that, a couple days go by and the baby goes back to breech. That is a risk of the procedure. This, to me, is one of the more mild risks when you think of the ones above it. All right, so our nursing functions, right? We get mom's vitals. We get them during the procedure as well. You can expect her vital signs to change because she's in pain during this procedure. And then again, you need to monitor the fetal heart rate before, document that reassuring non-stress test. And then for about 2 hours, we need to monitor her after the procedure. She will get an IV placed before this procedure because if you think about it, at its worst, we could end up in an emergency C-section during this for fetal distress. So if that's the case, we'd want to have an IV access already in place. Okay, an internal version is something that's a little different. A provider would reach in and internally rotate a breech baby if it was a second twin. So meaning twin A would come out vaginally head first, and then if the second twin was in any other position, the provider could reach in and internally rotate. We don't do this in singleton pregnancies. It really only happens with a second twin who was not vertex and we're trying to deliver that second twin vaginally. So as I'm saying this, you might be thinking it. A woman with twins could have one baby delivered by C-section and one baby delivered vaginally, so baby A, and the next, baby B, there is a risk that if we can't flip that baby around or if that baby goes into stress, that she needs a C-section for B. There have been cases that happen that way. Okay, to talk a little bit about operative vaginal deliveries. Operative doesn't mean we are cutting her vagina, but it means we're using a tool vaginally to take the baby out. So those two things are forceps, which here look like salad tongs, and a vacuum, which really is more like a suction cup, okay? Why would we use these? Sometimes a woman just gets to a point where she needs that little extra help to deliver her baby. She's exhausted. It could be that the baby is in distress, and these measures may save about 10 to 15 minutes of her pushing, and we need that baby out. We can't let that baby sit in distress for those 10 to 15 minutes. Rotation of the head. This would be if a baby is in the OP position, the posterior position. We know that that baby's head is much wider in the posterior position, and these tools may help us to rotate the baby's head to aid in delivery. Okay, so forceps, we don't see it sort of a dying art. There are a couple of providers who are well versed in them, and people who know how to use them can use them really well. They get put on the baby's head, and as mom's pushing, you can see down here in image D, the provider is going to be applying pressure to the baby's head with these blades and pulling the baby out. Big risk of tearing vaginally for mom, right? These are going to cause some severe lacerations on mom's vagina and perineum. Okay, so what to focus on in terms of is nursing care. So you want to explain to her what's happening, that she still needs to push, that as the baby's born, it's likely going to be bruised and reddened, and you might be able to see where those forceps are. Typically, the best time to use forceps is either the fetal head is low or we're using them as outlet. So it is not good practice to put mid forceps on because if the head isn't low enough and we're trying to pull the baby out, there's a lot of risk for complication there. Okay, other things to think about as the nurse. To provide adequate room before the provider uses those forceps, to make sure there's enough room for that baby to come down, make sure you catheterize her first. Make sure she has an empty bladder. Make sure the fetus's heart is well documented before doing this. Remember that she may need an episiotomy or she's going to be at risk for much more tearing because of this and what the baby is going to look like. I'm going to cross off this line, and you should cross it off on yours too. I will talk about that in class a little bit. Okay, the vacuum is the other portion of an operative delivery. And again, when I say vacuum, it's more like suction cup. The nurse is the one who's going to hold this vacuum pump and pump up the gauge. And then what the provider will do is hold the traction handle, and as the woman's pushing, suction has been applied here as the pump got pumped, and when she's pushing, the provider will pull. If there are pop-offs, meaning the vacuum pulls off as she's pushing, when we have 3 pop-offs, the provider should no longer be applying the vacuum. Probably the baby is not going to fit, and we stop trying after 3 pop-offs. And we would move to a C-section at that point. That's what a vacuum looks like. Again, more of a suction cup. An episiotomy, this is a bit of a review, so I just want to show you this in context, right? If she has any of these operative deliveries, the provider will likely cut an epis to make room for these instruments. So an epis is the abbreviation for episiotomy. Again, medial lateral is preferred because you're getting away from the anus. But again, we still run the risk of that happening going into the. Okay, so it talks here about the advantages of medial lateral, and again, that's the one that if we're seeing them, medial lateral is the better one to have performed. All right, guys, and what I will do is pick up in class with any questions about this material, and then we're going to discuss C-section and shoulder dystocia, and then we'll do the case studies in our clinical groups, and we will be acting them out again. Thanks, guys.